Hi. It's a very unusual place for us because we usually film in the proper hub and studio, but now we're in the cafe, in one of the best cafes in Kyiv, which I think is nice. And I am very grateful for you that you agreed to come. How come overall that you arrive to Ukraine during the war? Are you totally fearless?
Well, I think we had a really good reason motivating us for this visit, and certainly my last two visits. We're both British doctors who really want to try and help in whatever little way we can patients in Ukraine. And Henry invited me to Ukraine because I'm a palliative care doctor, and the whole of palliative care in Ukraine is struggling under the conditions of war right now. And we have set up a little charity in the UK called Hospice Ukraine to try to help teams here in Kyiv, in Lviv, and that's why we're here.
As to my knowledge, you brought Rachel here long before the war, correct?
No, I wanted to bring her before the war, before the pandemic, because I understood that palliative care in Ukraine was unsatisfactory, and palliative care in England, the hospice movement started in England, and English palliative care is very famous. So we had become very good friends. We're both writers as well as doctors. And I thought, yes, Rachel in Ukraine, that might make some magic. But bringing Rachel to Ukraine is like putting a snowball on top of a mountain. And it's been an avalanche ever since, because she is an extraordinary person. And now, like me, she has become infected, enthused with our deep concern for what is happening in Ukraine. We cannot change the war. We cannot change what will happen. But as doctors, we are just so anxious to do what little we can to help our colleagues here.
Both of you are famous writers, and Henry is published and translated and republished and sold and resold. And in each audience where I work with the doctors, somebody definitely has read his books. What about you? You were published in Ukraine, correct? With which book? Tell a little bit about your books.
Yes. So my book about palliative care is called Dear Life, and it was published in 2022. It was meant to be published the week that Russia invaded, but it was published 6 months later. And I came to Ukraine and we had a book launch in a bomb shelter in Lviv, which was an extraordinary experience for me. But I was so delighted that this book was translated by a wonderful doctor here in Kyiv, Dr. Andriy Mizak, because as a palliative care doctor, I believe that so much of the suffering around death and dying can be helped, can be avoided if we talk about these difficult topics, if we make sure that the patient is at the center of everything we're trying to do as doctors, if the starting point of palliative care is a really simple question: what matters to you? You may have a very short amount of time left to live, but you are still a human being who loves, who cares, who can enjoy life. So what matters to you, and how can we help you enjoy your life as long as possible? And that's what my book is about. So I'm delighted that it's now in Ukrainian.
I will be a bit provocative. When you, Henry, learned that Rachel's book will be translated and published in Ukraine, did you believe that it will be ever sold? Because you were in Ukraine many times in the 90s. Do you really believe that people would go into discussing this topic?
I had no idea. I did not know, but I knew it was a very good book. I knew that palliative care, conversations about death are not handled well in Ukraine. So I thought it is a good thing to have it published. It may sink like a stone, but life is all about trying to do good. We may not be successful, but the important thing is to try. And we judge people by what they try to do, not necessarily by whether they are successful or not.
You diplomatically called it unsatisfactory. When you say unsatisfactory, what do you mean and how do you view it? What is unsatisfactory palliative care in Ukraine?
We are all frightened of death. I've advanced cancer myself, so I've had to think a lot about my own death in recent years. But the problem is we often project our own fear of death onto other people. And there is a tendency to hide, to push death away, let them go away and die. I'm all right, I'll go on living. And that means many people, when they are dying, suffer unnecessarily. And what is so wonderful about Rachel's book and her work is it shows that the last few weeks or months, or maybe years of our life, are very precious. And they should not be brushed under the carpet because all of us are frightened of death and dying. And it was clear to me, having worked in Ukraine for many, many years, that people here found it very difficult to actually look at death in the face and try to make rational, sensible decisions about how to deal with it.
And for you, when Henry says unsatisfactory?
So it's very interesting because in Ukraine, there are some exceptionally good palliative care
like
doctors.
Zoya Maximova, for
like
example.
Zoya.
Exactly.
She is just the dream palliative care doctor because she is so strongly motivated by this simple idea. This patient in front of me, they may have 1 week, 2 weeks to live, but they matter. They're living now, and my job is to help them live. And that attitude requires you to not hide away from death. So if you never tell a patient, for example, that they're dying, if you never ask them the question, would you like to talk to me about what you're most afraid of, then you are denying your patients the chance to talk about their worst fears and to look at how you can help them as a doctor. And Zoya is a wonderful example of a doctor who is not frightened of those conversations. And they are a key to unlock good palliative care for that patient at the end of life. So what I have seen in Ukraine are examples of the best palliative care. And that might be morphine, but it might be something very imaginative. For example, one of Zoya's patients, a young woman dying of cancer, do we need?
No,
Shall I carry on? Okay. Yeah. So, for example, one of Zoya's patients, a young woman dying of cancer, Zoya said to her, is there something that I could do to bring you happiness? And she said, yes, I want a manicure. So here in Kyiv, Zoya organized for a manicurist to come and paint her nails. And this young woman said, I want a Ukrainian flag on each nail. So she died celebrating her country in the face of war. She died with her Ukrainian flags. And that meant something to her that was beyond morphine, beyond drugs. It was about her as a human being. That's good palliative care. And I would love, and doctors like Zoya would love, that attitude to spread more widely. Let's talk about death and dying, because if we do, it's a way to take away some of the fear, some of the stigma, and to actually help patients feel as though they're still human beings. Because the fact that you have a terminal diagnosis does not mean you stop being a human being. You are a human being. Let's treat these patients as the human beings they are.
So you have to see dying as an opportunity rather than something just to be got over with as quickly as possible with least stress and embarrassment for everybody else.
One of the questions which comes up immediately when the palliative care topic is on the table is the pain management.
Yes.
And actually, when we look into it, it's not only in palliative care, it's the overall attitude to pain and the pain management, even if it is not a palliative care patient. How do you culturally or mentally explain the phenomenon that even with the quite well done documents from the Ministry of Health, availability of different drugs, still it's not working? What is the phenomenon behind it?
Even in more developed medical systems like in England, pain relief, for instance, after surgery is often done badly. I think this is because all of us in healthcare have to find a balance between sympathizing with our patients and being detached. And we do not like patients to be in pain. It hurts us. And it is easier sometimes to deny that the patient is in pain rather than actually treat the pain. But we're doing that to protect ourselves.
But there's a particular problem in Ukraine and many other countries internationally around morphine, the strong painkillers. There is a lot of fear about using morphine because we know that in patients who are not in pain, morphine can be addictive. It's close to heroin, to other drugs that create drug addiction. So there's a lot of fear around using morphine, especially tablets of long-acting morphine. So I see patients in unbearable pain because they don't have pain relief. They want to die because of their pain. You start them on morphine tablets, and 2 days later, they walk out of the hospital because they have proper pain relief. But in Ukraine, there is so much anxiety around morphine and oxycodone, which is a similar drug to morphine, but associated with addiction, that they're not prescribed. So, for example, you will go and visit a patient in their home and they can't get the tablets. They have to take morphine syrup that only lasts for a few hours and they're in pain. They take some more, then they're in pain. So their life is dominated by pain. And we could fix that if we could change doctors' culture around morphine and oxycodone. And I think if there was one thing we could change now in Ukraine, it would be the attitude to morphine and oxycodone. Let's look at how safely we use those drugs in the UK, for example, how fantastically good they are at helping people who are dying. And let's be braver in how we give them to patients here.
At the same time, you have to avoid what happened in America with OxyContin, where they were using opiate drugs for treating non-malignant, non-terminal conditions. So it has to be very carefully regulated.
You were coming here before the war, right? You were here.
I first came 6 months after the war.
During
yes,
the war. Okay.
Yes.
In fact, we arrived in the Vauxhall the day the Russian cruise, exactly at the same time as the first of the cruise missiles. So we arrived with a bang.
So what do you think the war makes how does it influence the whole palliative care?
It's very interesting because wars are clearly horrific to live through, but they also generate a lot of innovation, new ideas. So penicillin came out of the Second World War, for example. And I think perhaps for palliative care in Ukraine, strangely, the war is an opportunity. Nobody can hide away from death and dying at the moment. For 3 years, death and dying has been in every Ukrainian's heart. Everybody knows people who are dying in their own homes from Russian missiles on the front line. Everybody knows people who are dying. And perhaps that has generated an attitude of willingness to look at the fact that being a human being means being mortal. We are all dying from the moment we're born. We just don't know how long we have. A patient in palliative care is the same. It's just that they have more idea about when they are dying. But we are all mortal. None of us can escape it. And that fact has been made so enormous in people's minds by the war. So I think there is an opportunity here. We can't hide from death and dying. None of us can. Let's look at it and say to ourselves, when someone has a terminal illness like cancer, let's look at this so that as doctors, as nurses, we can do the job that we do with all our other patients. How do we prevent suffering? How do we help this patient live as well as they can for as long as they can? And I think perhaps the war has created conditions in which it's easier to do that.
And then, according to you, how did war affect the whole thing?
The honest answer is I don't know. I mean, neurosurgery is a very minor part of battlefield war surgery. 75% of military deaths are from head injuries. We cannot stop that. So as a neurosurgeon, I have nothing to offer, and I have little understanding of what's going on. So the answer is I don't know.
What's the difference between palliative and hospice?
So a lot of people think that palliative care is only people who are dying soon. It is about caring for dying people. But actually, palliative care is care for anybody who has a life-limiting illness. But they might live for 2 years. They're not dying today. They know that they have, say, a cancer that can't be cured, but they still may have a long time to live. So palliative care, part of it is end-of-life care for dying people. Part of it is for anybody with a terminal diagnosis. So Henry is an example of somebody who has a cancer that can't be cured, but he is most definitely not dying.
Not yet, no.
He looks fresh,
He
very
looks
much.
pretty fresh.
Well, I run most days, and the weather's
Yeah.
terrible today. I'm not running today. But
So that's a big misconception about palliative care. In the UK as well, people think palliative care means death. It doesn't. It means life and living for as long as you can, as on your terms. And in a hospice, again, people are often very afraid that a hospice is a place you come to die, and it isn't. Some patients will come to a hospice to die, and they will spend their last days, weeks in a hospice. But some patients will come to a hospice because they have symptoms that are really difficult to look after, such as pain. They'll come to the hospice, they'll spend a week being looked after by doctors like me. We'll help their pain, we'll get them moving around. Then they'll go home, and I'll say to them in the nicest possible way, I hope I never see you again. And they'll laugh and say, me too. And they may come back 6 months later, a year later.
And there's a very important part of hospice palliative care in England, which is you have mainly nurses visiting patients in their homes. There's a system called Macmillan nursing, which is specifically to care for people with a life-limiting illness in their own homes. And that is where I need to talk about what Rachel has achieved over in Lviv. Bringing Rachel to Ukraine, as I've been telling everybody, is rather like putting a snowball on top of a mountain, which then starts an avalanche. So through the kind work of Dr. Mizak, we went to a Ukrainian-style hospice in Sambir, a small town near Lviv, and we talked to them. They're very nice people, very modest, very nice hospice, very clean, very well run. And they said, well, what we do need really is a car, a Jeep, a 4x4, so we can visit dying or very sick patients sometimes in quite remote Carpathian villages with terrible roads. And then 1 year later, through entirely Rachel's work, earlier this week, we took a Land Rover Defender to the hospice as a mafia machina to act as a palliative care ambulance in Zambia. And that's all Rachel's work.
So you brought the car from...
Well, we bought it in Kiev. It then was taken to Zambia on a transporter. But this was all due to... I would never have dreamt of doing that.
You mentioned a fund, right?
Yes.
Tell a little bit more about the fund.
So the charity Hospice Ukraine is a British registered charity, but we raise money to support palliative care teams and hospices here in Ukraine. So all the money we raise goes to supporting teams here. So Zoya Maximova does incredible work going out to visit patients.
And you helped her with money
yes.
for fentanyl.
With the fund,
yes, and so we are helping provide more medical personnel, more nursing personnel. And the thing that we really want to do with Zoya and with Elena Parachuk, who is the palliative care consultant in Zambia Hospice, we want to build a palliative care website for doctors, nurses, anybody who wants to use it in Ukraine, that is a resource for how to treat patients who are dying, who need palliative care. And this is partly the medicine, the drugs, how do you treat pain, breathlessness, but it's also the philosophy. How do we help somebody who is close to the end of their life feel as though life is still meaningful? And we hope to, with this fund, we hope to be able to bring Ukrainian doctors each year to the UK to spend some time in a British hospice, see how we do it there. So lots of exchanging of ideas, big plans.
And the idea is to raise the profile of palliative care in Ukraine, that this is actually a very important part of medicine, is not to be seen as a rubbish dump where we
which it is,
where dying people are pushed away. And in fact, as you can see with people like Rachel, that palliative care can be a very rewarding branch of medicine. Rachel often says, people say, it must be so depressing only looking after people who are going to die. And she says, no, it's not. It's a hugely positive, life-enhancing experience.
Yeah.
People have a few weeks or months to live, and you're trying to help them make those a good time, not just waiting to die, but looking back in their life, talking to their families, understanding what's important in life.
Yeah. How many books you wrote?
I have now written 4 books.
I'm very jealous. That's one more than me.
And in fact, my next book, Andriy Mizak is translating into Ukrainian, so it will come out in Ukraine.
In Starovoleva?
Yes,
okay.
Yes. And that is about heart transplantation, and it's about a child whose life was saved from the transplant of another child's heart. And it is
a child killed in a road traffic accident.
It's the story of these 2 children and interviews with all of the doctors, the heart surgeons, the nurses, the families, telling the story of this transplant.
And there is a scene in the book which is very difficult to read without bringing tears to your eyes, and I'm going to start crying now if I'm not careful, where the parents of a child who died listened to their dead child's heart. In the child, in the body, in the chest of a child who had the heart transplant. I mean, it's an extraordinary scene. Quite extraordinary.
A recent story in Ukraine because it's very rare now. It's only starting in Ukraine, the whole thing.
Yes.
So there was a recent story in Odessa Oblast with the child who basically saved 5 other children.
Wow!
But the doctors who participated directly in this story was telling me, and this was heartbreaking, of course, how they were convincing parents to do it and stuff like that. Your first book was on palliative care?
My first book was about what it was like being a very junior doctor in the UK, where there are, that there were all kinds of problems. The NHS is not perfect. And it was about
it's a political book, basically.
It is quite political, but it's about how hard it is as a young person to start to be responsible for the life and potential deaths of patients. If you make a mistake and you misdiagnose your patient, they may die. And how do you learn to carry around that responsibility as a young doctor?
And your book on palliative care was translated into Ukrainian.
Yes.
Do you know anything about your British readers or Ukrainian readers? Who actually is reading your book on palliative care?
Well,
and what are people saying?
So I know more about the UK. In the UK, the books have been very popular. They've all been bestsellers. And the book Dear Life about palliative care, I was very surprised. I thought perhaps nobody would want to read a book about death, but it was a big bestseller, and lots and lots of people still today write to me to say, I have terminal cancer. I have read your book. It has made me feel less frightened. Thank you for writing it. Or a family may write to me to say they read my book so they could understand more about what it would be like when their loved one reached the end of their life. And they have found it so helpful because it has taken away so much fear. So I think the lesson is the more we pluck up the courage to look at our mortality and learn about what happens when somebody dies, the more we can take away fear and trepidation, not only for patients, but for their families as well. And I think that I have an expression that I use when I teach medical students, which is in a really, really profound sense, we only die once. So you get one chance to get it right. And if you can get it right, it is not just a blessing for the patient. It is so important for the family because they can take great comfort into their future that the person they loved so dearly died with dignity. They were not in pain. They were surrounded by loving care at the end of their life. And if you can achieve that for a patient and their family, that's why I get up and go to work in the morning. That is magic. Best thing in the world.
How did you meet Rachel?
She wrote to me after I published my first book, Do No Harm. And she wrote to me via my literary agent because there's strange parallels between our lives. We both, Rachel's 20 years younger than I am, 25 years younger, I think. But we both went to Oxford University, where we studied politics, philosophy, and economics. I probably would have become a Kremlinologist. I studied Soviet politics under a very famous Kremlinologist called Professor Archie Brown, who told Margaret Thatcher that Gorbachev was the up-and-coming guy in the Politburo. And Rachel studied politics, philosophy, economics. We both got first-class cum laude degrees. She became a journalist and even a war correspondent at one time. Extraordinary life. And both of us had sort of emotional crises in our lives and both decided to become doctors. I became a brain surgeon. She became a palliative care doctor. And you might think those are two very opposite branches of medicine, but in fact we understand our view of medicine is so similar, so much the same. And she wrote to me and said, can we meet? Because she lives near Oxford. My wife lives in Oxford. I spend half my time in Oxford. And we immediately understood we had the same outlook on life. So bringing her to Ukraine for me was a very obvious thing to do. And the fact it's gone off like a rocket is not surprising.
And you became a palliative care doctor from the start. You were not some other doctor.
No.
Why this choice?
Well, you were a physician and you trained as a general physician.
Yes, I did training in all areas of medicine.
Of course.
I specialised in palliative care. So I think because I was a journalist to begin with, and part of current affairs journalism is trying to give a voice to people who are not always heard. You want to advocate for people who are, suffering. I came to medicine with that attitude. And even in medical school, I could see that there were hierarchies in medicine. So brain surgery, the rock stars, they are the top of the hierarchy.
Rubbish, of course.
Palliative care doctors.
Yeah, but they cut somebody's head off, then they sew it back, they change everything inside.
That's probably quite tricky. Palliative care doctors, low down. And palliative care patients, so low down, particularly vulnerable. So I remember as a medical student, I was on a ward round with a surgeon, with all the junior doctors. We saw this patient, we'd looked at his scan, he had a new diagnosis of cancer, his abdomen was full of cancer, he was going to die. And as the surgeon turned away from the patient, he said to me and the junior doctors, "There's nothing I can do here, send him to the palliative dustbin." And I looked at that surgeon and thought, I didn't say it out loud, but I thought, that is disgusting. That is a human being. He is a person. He has value. He matters. The fact that he has a terminal diagnosis does not take away his value. So even then, I thought, I want to work with these patients. I don't want them to be treated badly, to be left and forgotten in the corners of the hospital. I want to advocate for them. And then I discovered that palliative care patients were every bit as remarkable as any other patient, but perhaps even more so when you know you are dying, all the stuff that doesn't matter falls away. The only stuff that matters really is the people you love, the things that are meaningful for you, all the boring stuff. No one cares about how big their house is or how fast their car is or how successful they were at work. They care about the stuff that matters. And I find it so endlessly interesting and rewarding and moving to work with these patients. I feel as though every day at work, I see human beings at their very best, at their finest. They show courage, compassion, great resilience, great bravery. And it is my privilege to work with them. And I genuinely love it. I just love it to bits because I see the best of human beings.
How did this part of medicine, palliative care, how did it change in the last 20 years in Britain? What is the trend?
So it's a very young specialty. It was invented in the 1950s in Britain by Cicely Saunders, a nurse who became a doctor and set up the first ever modern hospice in the 1950s. And in the last 20 years in the UK, there has been a great movement to talk about death and dying. So in the UK, still death is a taboo. People are frightened of it. But in the last 20 years, we are talking about it more and more. And that's a wonderful thing. So patients know more about what is likely to happen at the end of life. There is, though, a big problem which has not been fixed at all in the last 2 decades, and that is palliative care is it's a second-class medical specialty. It receives very little funding. So
it depends mainly on charity, 70% on charity.
So hospices in the UK only get between a quarter and a third of their funding from the government, from the NHS. The rest has to come from charities. And that's wrong. You know, the NHS is supposed to be, our phrase is cradle to grave. It's not cradle to grave. Dying people are neglected in the NHS. So there's a lot of campaigning to raise the profile of palliative care in the UK so that we receive the funding that dying people should have, because the measure of a civilized country is how well we care for its most vulnerable members. And if you have a terminal diagnosis, you are vulnerable. So you should get the best care, not sort of leftovers.
Is the approach the same with children and adults?
Yes. So the funding of children's hospices in the UK is even worse than adult hospices. And only last month in the UK, a hospice for babies in the north of England announced it was going to have to close because it didn't have the funds to stay open. And this became a national scandal. Lots of people raised money. Now it's staying open. But that's mad. A hospice for babies having to close in a country as rich as the UK. So children's palliative care, when children can get it, is absolutely brilliant. And a children's hospice, is a place where there will be drugs, there will be lots of important medicine, but there will also be miniature ponies and Easter chicks, wonderful clowns, beautiful, gorgeous play for the children, really looking after the child patient as a human being, not just as a person who has cancer. So it's a vibrant, imaginative type of medicine, but boy, is it underfunded.
And coming back to palliative care, a lot of things which I see in Ukraine, for example, there is a patient, fresh and beautiful, like Henry,
so beautiful.
Yeah, so beautiful, and running around and working and traveling and everything. But then if this cancer patient comes to, I don't know, let's say cardiologist and needs cardiosurgery, for example, stent or anything, the cardiosurgeon would like,
no way, too scared. Yeah.
Is it the same in Britain or it changed?
No, I don't think so. I think you judge patients on what they require. I don't think having cancer is not seen as a no-no. No. Well, it depends. It depends.
That's the first time they disagreed on this air. Okay, continue.
We like to have healthy disagreement. Sometimes, Henry's right, you treat the patient in front of you as the patient. But there are some surgeons in the UK who are prejudiced and who assume, without discussing the matter with the patient, that because they have a diagnosis of stage 4 cancer, obviously they shouldn't have the surgery. I think it's true.
But the problem with here is, if you look at America, where they don't know when to stop, over-treatment. I mean, if some analysis of healthcare in America by doctors is that 30% is wasted money. So it is a very difficult problem. When do you stop treating people?
But there's a very simple answer, actually, I would say, to the problem. The simple answer is, you, the doctor, are not the person who should be making decisions for your patient. There is one question that matters, and it is, what is important to you, the patient? So
I completely disagree with that. Because as patients, we are often terribly unrealistic about what is good for us. We will cling to hope. We will subject ourselves to terrible operations, to terrible chemotherapy for a 1 or 2% chance. So it's more complicated than that. To say the patient always knows best is not always the case.
But that's not what I said.
All right. But,
so you talk to the patient and you say, there are these options. We could do nothing.
Yeah.
We could do surgery. You explain the risks.
Yeah, but then
of surgery. Hang on. And you explain to the patient very clearly, give them the information, talk to them, find out their views. So if they say, I must have the surgery, I must have it at all costs, then you say to them, I think if you have this surgery, or the statistics show, there is a 90% chance you will not survive this surgery, or you will be left disabled. So your job is to communicate the information very, very clearly and support the patient in understanding the facts about the different options. And if you do that, most patients will choose wisely. But in America, I think often the doctor will say, yeah, let's go ahead and give you a third.
But it's also a folie à deux. I mean, in America, as Woody Allen said, death is optional. There is this American optimism. The problem is, yes, obviously, the fundamental principle of good medicine, which is often lacking here in Ukraine, is we make decisions with patients. We do not make decisions for patients. But the difficulty is the way we present the options, our own emotional biases as surgeons, as doctors, about the options often makes it very difficult. And in reality, most patients' decisions most patients make will be almost entirely determined by the way the information is presented to them by the doctors. So I agree with everything Rachel says. All I'm saying is it's terribly difficult sometimes.
Speaking about decisions, when I was a kid and then when I was in the medical university and even became a young doctor, it was still a tradition not to tell the patient that he or she has cancer.
Yes, England was like that 40 years ago. That's changed. You told the family one thing and you never told the patient. And the family, you mustn't tell them they're dying, which of course creates then a huge difference.
But it quite often was not even about dying. It's just about cancer
at
all. Even the patient is not dying, but just going to the operation.
Yeah.
So legally, can you not say the patient now in Britain, or you should?
No. You have to ask the patient how much they want to know.
Yeah.
Okay.
So if a patient says, don't tell me anything, you will make sure they really mean that, and then you'll respect that. And occasionally, I'll meet a patient who is sometimes very close to the end of life, and they do not want to discuss that, and you respect that. And sometimes you'll have a family that they're happy for you to talk to their family. So the family know that dad is dying, but dad will not have it. But much more commonly, you'll meet a family.
And the family say, don't tell them.
Yes. So the family and the patient are pretending to each other they don't know the diagnosis. And sometimes my job will be to say, shall we all have a conversation together, perhaps, about what's happening? Would you like to do that with me, helping you talk about this? And you'll have a conversation where dad says, I know I'm dying. I know I've got cancer. And then the grown-up children will cry and say, we didn't think you wanted to know. And the dad will say, but I was protecting you. And they discover a very beautiful thing, that they were all trying to protect each other. And once it's out in the open, everything becomes easy.
There's another aspect to this, which is really, it's terribly simple. When I lecture to medical students, when you meet a patient for the first time, the first question is, what have you been told? What do you understand? And what are you worried about? That should be the beginning of any medical conversation, whether it's palliative care or brain surgery or anything. And it's such an important thing. You cannot make decisions with patients if you don't know what they are worried about. But it takes time, of course,
What is the role, and if there is any role, of a psychologist and psychiatrist in palliative care?
Really important, because when any of us are given a terminal diagnosis, that has an immense psychological impact. You've been living your life assuming it goes on forever. We know theoretically we'll die one day, but that's in the distance. It's not something to worry about. And now suddenly you are being confronted with a profound existential change in your life. You are going to die soon and you have to confront that. And of course, often people's initial reaction is to be very, very frightened and sometimes very depressed. So there's a great role for psychological therapy. But interestingly, a lot of patients actually, you don't necessarily need a psychologist. You just need somebody to talk to them about what's happening. And that could be a nurse, it could be a palliative care doctor. But if you ask, I find a very simple question that I like to ask all my patients, it's so powerful, is this question. Please tell me what it is you are most afraid of. And then you are giving them an invitation to reveal their deepest, darkest fears. And often they will say, it's not being dead that I'm most afraid of. It is the experience of dying. Will it be very painful? Will I lose my dignity? And the act of talking about that starts to take away some of the fear, because I can say, would it be helpful for you to talk to me about what my patients typically experience at the end of their life? And if they are getting good care, it usually is not awful. There's not terrible indignity. There's not terrible pain. So having a conversation now with that patient about their worst fears is surprising to them. They realize it might not be as bad as they think. And then the other very powerful idea is often psychologically patients, when they get a terminal diagnosis, they think, my life is over. There is no more living to do. I've just got dying to do. And if you can help them reframe their biography and think, well, what do I still enjoy? I enjoy time with my family. I enjoy fresh air. I enjoy nature. How do we make sure you have as much of that as possible? They start to feel as though maybe a terminal diagnosis does not end living. Living continues. You're still alive. We can still help you experience it.
Rachel had a patient who was a farmer, and she tells a story in her book who loved his prize bull. So Rachel arranged for the prize bull to be brought to the hospice.
Yes.
So he could say goodbye to it.
Yes. We said to his wife, what does he love most of all? And his wife rolled her eyes and said, well, he loves that bull far more than he loves me, so you'd better get the bull. So we did. We broke a few rules, not very good for hospital health and safety. But this bull just intoxicated the dying farmer. He was so happy, absolutely thrilled, died a few days later. Beautiful palliative care. You don't prescribe that from a bottle, but it's great care.
The question about the system a bit. How when we speak about the hospice, clear that it's a separate hospice, either department or the separate hospice as a facility. But when we speak about the wider palliative care, not end of life, not hospice, but just palliative care for fresh and beautiful people, is it a specific doctor? Is it a specific department? Is it in each department because the patient might come to any department, cardiology, I don't know, therapy, whatever. So what is the best way?
So there are 3 places where palliative care happens in the UK, and it's this, just to some extent the same in Ukraine. We have hospital palliative medicine in a hospice, and then community palliative medicine where we go into people's homes. And for example, I now do hospital palliative medicine. So any doctor in the hospital, it could be in intensive care, on a medical ward, a surgical ward, the emergency department. If they have a patient with a terminal diagnosis and they're not sure what to do, they need our help, they will phone and we will go and support them, see that patient. But the idea that the best model is one in which, yes, there are a few palliative medicine specialists and nurses, but the best model is one in which palliative care is integrated in medical education so that every doctor knows a bit. And ideally, I want to get rid of my job. I want my job not to be necessary because every single doctor is confident in caring for dying patients. Every single nurse has that confidence. Clearly, that won't happen, but I would love a world where palliative medicine was a core part of all medicine. That's the fantasy. But for now, there's a small number of palliative care specialists, and we are called upon when other teams need our help.
The problem is it's the downside to specialization. I can tell you a story about my wife who was in hospital with severe Crohn's disease, in severe pain, and she had she'd been on huge doses of morphine. But there was a pain control team because they were the pain control team were better than the average ward nurse at controlling a pain. But the nurses on the ward were no longer allowed to prescribe her painkillers. It had to be done by the pain control team. And the problem was at the weekends, there was no pain control team. So my wife was in terrible pain all weekend because the nurses said, no, we can't prescribe the pain. So it is the downside with specialization. Same with palliative care. If you say it all has to be done by the palliative care specialists, the regular ward staff will say, that's not my job, you know. So as Rachel says, ideally, it's not as though pain control is that difficult or palliative care is that difficult. You want to train this as part of all doctors and nurses' armamentarium.
What's the profile of the people who go to work in palliative care? If you can say something like this, if you see some general features.
It tends to be doctors who are very, very interested in their patients as people, and who care a great deal about communicating well with patients. They have a strong desire to be able to communicate with a patient group who are very frightened often and very vulnerable often. It tends to be doctors also who love general medicine. So palliative care, the diseases we work with affect every single body system in the human body, you know, the heart, the liver, the kidneys. So you have to be really good general medics to be a good palliative care doctor, in the same way that a good pediatrician has to be a very good basic doctor, because you need to understand every bit of the body. If you're a cardiologist or a renal physician, you're focusing on one body system.
It's mainly women.
It is mainly women. That is beginning to change. Mm-hmm. And I think that is partly because of the status of the specialties. So in Britain, historically, you know, surgery, male-dominated profession, high status, highly desirable for a lot of sort of alpha men. Palliative care is like pediatrics in that respect, doesn't have the status.
Women, mainly women.
Yeah, it's beginning to change.
But it's not that much emergency work, and the training is different as well. It's easier to bring a family up and be a palliative care doctor than train as a surgeon, perhaps.
Maybe. I mean, you still do your nights and weekends.
Yeah.
So, yeah.
COVID. I heard rumors that you wrote a book or a screenplay on COVID.
Both.
Yeah.
Tell about it.
So when the pandemic began, I was working in a hospice, but I wanted to move into the hospital to care for COVID patients. My skills I knew would be very, very useful.
Support and all that.
Yeah, and caring for patients who were very frightened, dying very quickly from COVID. So I worked on COVID wards and experienced, as so many doctors did, just astonishing numbers of people dying from this disease. And the majority of patients did not die in intensive care. They died on ordinary medical wards with essentially very little that we could do for them. So palliative care was really important.
And they died from respiratory failure, which is not a good way of dying.
And their families could not come in and be with them in the same way because of infection control. So we had to have end-of-life conversations on iPads, on screens, on phones. And it was heartbreaking, really tough.
And it's, you cannot reject family, this?
So to begin with, families were not allowed in, even when their loved one was dying. Quickly, we did allow families to come in at the end of life because it was barbaric not to do that. But often, a lot of the patients were elderly, and their husband or wife would not come in because the risk to them of catching COVID and dying from it was so great. So many, many patients died without a family presence. And that was so...
The reason why I re-asked whether the phones and iPads were allowed and whether the whole family was in contact with patient, because in Ukraine it was not like that, and it was quite often a reason of later trauma for the whole family that they were never put in contact and they never even knew how
not
the person
even with
died.
a screen.
No.
Wow.
No. That's why I re-asked several times.
Yeah. So we very quickly realized how important it was for families to see what was happening. The first patient that I saw with COVID, I was in my PPE. I realized something horrific. I realized that every patient who came into the hospital and died in hospital, from the moment they arrived, they would never see another human face again. Everybody they saw had a mask. And that is so wrong. When someone we love is dying, with every fibre of our being, we want to be with them. You want to hold them, touch them, be close to them. And sometimes in my hospital, I would see cars in the empty car park, somebody sitting in the car staring at the hospital. And this was a relative who couldn't go inside, but they were there as close as they could get to the doors of the hospital because of that impulse to be close to someone you love when they're dying. So we realized that we had to find a way of connecting families to the patients who were dying. We used screens, we used medical students. So in Oxford, the medical students were trained to phone up family members and update them on what was happening to their loved one, and also to have these video calls so that they could see and talk to their loved one. And sometimes we would play their favorite music. We would read out letters. We would have a wife singing to their husband as he was dying of COVID. And it was extraordinarily important for helping families feel as though they were connected.
So you wrote a book about it?
I wrote a book, yes. And the book was the first 3 months of the pandemic as they unfolded, as it felt to be a doctor on those COVID wards, dealing with the death, dealing with the lack of PPE, dealing with the chaos. And then I co-wrote a screenplay, and it was turned into a television series that was broadcast.
So it's already broadcast?
It's been broadcast in the UK, yes.
It was very powerful.
Yeah.
Very powerful.
And was, watched by 6 million people. Hard for people to watch.
Because my cancer was diagnosed at the height of the pandemic, and the few conversations I had with the oncologists were all wearing face masks, and it kind of doesn't feel quite right, It all makes it feel rather abstract. And it's very odd.
So before we finish, first of all, let me thank you again for coming. Let me express the hope that I will see you again and we will film again. But 2 questions. What you didn't say that you will regret of in this interview? Would you like to say something? And second, what are your plans for this visit to Ukraine? What are you guys going to do?
Well, I'm really here. Margaret Thatcher, I'm no fan of Margaret Thatcher. She had a husband called Dennis Thatcher who went around sort of behind her drinking gin and tonic. And on this visit, I'm in my Dennis Thatcher role.
Wait, that makes me Margaret.
Yes, exactly. Rachel is the star. So really, the main purpose has been to promote Rachel and palliative care.
Mm-hmm.
Well, I am so grateful to Henry for encouraging me to accompany him to Ukraine on that first visit in 2022 and now again. And I just hope that we can keep coming, keep building the profile of palliative care. We'll try and keep raising money in the UK to support teams here. And I cannot wait to sit down tomorrow with Zoya Maximova and her team, and we're going to be making plans about education, support between the UK and Ukraine for palliative care. And that is the most tremendous thing to do. And I have to say, the one thing that we haven't touched on in this conversation, but I'm very struck by is, and I sense you are perhaps another example of this. My God, there are so many strong, incredible, dynamic women in Ukraine. I have to say, I love Ukrainian women because I keep meeting these icons. You're just legends. And it's really amazing.
Yeah, we are indeed the country of women.
Yeah. You very clearly run the show.
That's true. So thank you both very much for coming. Hope to see you soon. And this interview will be seen by doctors, nurses, and not only. And as well, we'll send them the book. I mean, how it's called, Tarogoleva, which published it and everything, so that a lot of people can basically see and read it. Thank you very much.
Thank you so much.
Thank you.